Hi, this is Alexis Carter, and I am going to be speaking to you on Section 3C-2, Clinical Informatics for Pathology and Laboratory Medicine. These are the topics we will be covering. These topics have been covered by another speaker from the perspective of electronic health records, but today I will be covering them from the perspective of pathology and laboratory medicine and other ancillary systems such as radiology and pharmacy. I'm going to be using several abbreviations throughout this lecture. These should be familiar to most of you. I also want to specify that when I use the term laboratory or lab, this really refers to any laboratory that's performing clinical testing on a patient. It does not refer to research laboratories, as that's outside the scope of this lecture. When we talk about laboratories, this includes anatomic pathology, which is inclusive of surgical pathology, cytology, and autopsy, clinical laboratories, specialized laboratories, and reference laboratories. There's another abbreviation that is often used in circulation, which is LIMS, or Laboratory Information Management System. However, a LIMS usually refers to an information system used in a research laboratory and not a clinical laboratory, although you will find some variations in terminology there. In this lecture, I'm going to describe the relationship of EHRs with ancillary systems. While laboratory information systems will be used as the primary example, because as a pathologist, obviously that's my area of greatest expertise, we are going to touch on other ancillary systems such as radiology information systems and pharmacy systems. So I hope that you will consider this lecture to be more broad in scope than just pathology and laboratory medicine. We will be talking about architectures between EHRs and their ancillary systems, as well as support models for those configurations, and laboratory regulations and standards specifically that impact EHRs, because that's important for everyone to know in this very regulatory environment. The laboratory is also a primary example of an area in the hospital where there is a lot of automation. We use a lot of interfaces, we have automation lines, we have a high degree of barcode usage, and we also are starting to see an increasing usage in radio frequency identification tags. While these are things that can be used in many different areas of our healthcare systems, the laboratory can be used as an example to help describe those, but remember that you should be applying those to other areas and not just to the laboratory. We're also going to cover the basics of digital imaging, which obviously apply not just to pathology, but also to radiology, cardiology, and some other areas, as well as some of the issues surrounding telepathology. Nowadays, I think everyone is aware of the ever-increasing prevalence of genomic data in clinical medicine. It is having a broad impact on clinical informatics, and it's also important, I think, for individuals taking this board exam to understand where this data is coming from and just how dependent it is upon bioinformatics pipelines. We'll also talk a bit about genomic data privacy, because privacy in this arena is not necessarily intuitive and would be great fodder for board questions. In addition, we're going to talk about big data, what it is and what it is not, as well as a newer field in pathology called computational pathology, which is directly related to big data. So many of you may be wondering, why do I need to learn about the laboratory information system? And that would particularly be true if you are not a pathologist. If you look at the last bullet point on this slide, that should be one of the main reasons why you realize that you need to learn about pathology and laboratory medicine informatics for the boards. There are 3 pathologists who are colleagues of mine who helped develop the clinical informatics board exam questions, and there are definitely questions related to pathology and laboratory medicine on the exam. You know, there are a lot of obviously other good reasons to learn about the laboratory information systems and informatics. A laboratory information system is a classic example of an ancillary system to an electronic health record. We have a very similar architecture with radiology and pharmacy systems to the electronic health record. We contribute a huge amount of discrete data to the electronic health record. You will hear people often bandy about this phrase that 70% of medical decisions are made off of laboratory data. I think all of us realize that this is absolutely not true. Anyone who's been to medical school would know that. However, I think it is probably true that somewhere between 50 to 70% of electronic health record discrete data points are contributed by a laboratory system. If you think about the number of lab data points on any one patient, especially when you're talking about one lab result may have reference ranges, abnormal flags, notes, comments, other things about it, you'll realize that the laboratory does contribute quite a huge amount of data. Our workflows in the laboratory are highly automated. There's a lot of barcodes, we use a lot of robotics, and we are extremely highly regulated by federal law, up to and well beyond most of the rest of the healthcare environment. Our pathology residency programs actually require that our residents learn clinical informatics. There are publicly available teaching toolkits that we give to all programs, whether or not they have a clinical informaticist within their department or not. And those are available in the references. If you're interested in taking a look at them, they are freely available. So beginning with EHR to LIS architectures. With relation to an electronic health record, an integrated LIS is one in which the LIS is basically part of the EHR. It's either a module or component of the EHR. In this case, the LIS shares its tables with the EHR, specifically patient tables and other tables. Typically, in an integrated LIS, there are no HL7 interfaces required. In an interfaced LIS, by comparison, this is when your LIS is completely separate from the EHR. Typically, the LIS is from a different vendor than the one that has supplied the EHR, and communications can only occur through HL7 interfaces. When you're talking about an internal versus an external LIS, typically an internal LIS is where the LIS and the EHR are both owned and managed by the same healthcare entity. The external LIS is when your LIS is owned and managed by a different healthcare entity other than your EHR. So this would be an example where a hospital uses a reference lab for all of its all or some of its laboratory testing. The reference lab's laboratory information system would be an external LIS to the healthcare entity. With regard to an integrated LIS, or an LIS that is a component or a module of the EHR, there are advantages and disadvantages to these systems. The obvious advantages are that they may be less expensive at the time the contract is signed, although that can be short-term depending on what your maintenance fees are. There are no EHR HL7 interfaces to maintain. You typically have the same hardware platform as the EHR, which may create some economies of scale for you. And also, it may allow for some unique communication between the EHR and the LIS that can be hard to do with standard HL7 interfaces. Disadvantages, however, are that if you have an EHR that goes down on a periodic basis, whether that be for trouble or for maintenance, the LIS will have to go down with it if it's an integrated LIS. Functionality of integrated LISs can be more limited than those that are separate and developed by a company that specializes in laboratory. And that functionality can create the need for workarounds, but it can also create safety issues. Microbiology and blood bank, in my experience, are two areas where integrated LISs that don't have significant functionality may be particularly problematic. You also may have less ability in an integrated LIS to interface with middleware or with laboratory instruments, so it really depends on which LIS you're dealing with. And for these reasons and others, an integrated LIS may be more expensive long term. You may need more full-time employees, more third-party modules to be able to support the functionality that the laboratory needs with this type of LIS. There also can sometimes be some incorrect assumptions that because your LIS is integrated, that the displays of lab data are completely consistent between the EHR-facing view and the lab-facing view in the system, and that is not the case. So both displays actually do have to be validated anytime tests are being changed in the system. The LIS in this case also may not work in the absence of an EHR. Obviously, if the EHR goes down, it will go down with it. But in addition to that, the LIS often could not be brought into the laboratory as a standalone LIS. This is often not an issue in most places, but there are some integrated LISs that literally are not available to laboratories for use unless the institution has the EHR from the same vendor as well. Lastly, the integrated LIS may not work with EHRs which are outside of its LIS EHR configuration. For example, if you have a healthcare system with an EHR and an integrated LIS, and then that healthcare system brings on another hospital that has a different EHR, but they want all of their laboratory testing to be done at the integrated LIS laboratory location, that LIS may not be able to communicate with the outside EHR. And that can create some problems, obviously, for being able to function in that paradigm. There are also advantages and disadvantages of having an interfaced or a separate laboratory information system. The advantages are that a separate LIS will work in the absence of an EHR and almost always will work with multiple different EHRs because they're frequently developed by companies that specialize in lab whose flexibility is paramount to be able to interface with EHRs from multiple vendors. The functionality may be more tailored for laboratory, and anytime the functionality of a software system is more tailored towards the special needs of an area, you're going to see fewer errors and typically better turnaround time. It also may be less expensive in the long term because you may have less need to buy certain functional modules, third-party modules. You may not need to hire additional full-time employees to help support the functionality of the application. The disadvantages of an interfaced LIS is that it can often be more expensive at contract signature, which is the reason why many healthcare institutions are reticent to allow laboratories to bring on a separate LIS if an integrated LIS is available. HL7 interfaces to the electronic health record have to be implemented and maintained. You have to have separate LIS hardware, separate servers that have to be purchased and managed, which also will increase the cost. And there's some functionality that may not be available with standard HL7 interfaces to the EHR. There are some types of communication, dynamic messaging that may not be available. And in addition, even if you have an interfaced or separate LIS, depending on which LIS you have, you still may not be able to support more highly specialized laboratories such as HLA, genomics, or cytogenetics laboratories. LISs and ancillary systems in general can be managed by one of three different models. Institutional management means that the central IT staff or the healthcare entity manage the LIS as well as the EHR. This is a very common model when your LIS is integrated with the EHR. Laboratory or departmental management happens when the laboratory staff hires LIS analysts to manage and maintain the laboratory information system, and this can include the hardware, the software, as well as any network infrastructure required to help manage not just the LIS, but typically all of the software and capabilities within the laboratory, such as middleware, instrument interfaces, etc. Hybrid management is when you have the IT staff that manage the EHR also manage some but not all of the components of the LIS. So for example, a common hybrid model is where your central IT staff that manage the EHR also manage the servers, the hardware, and the networks on which the LIS runs. The laboratory staff actually manage the rest of the LIS, specifically any software builds, testing, maintenance, and especially compliance with the CAP and other laboratory accreditation standards with relation to laboratory information system management. It may be surprising to some that pathologists and radiologists are clinical informaticists, but hopefully not to many. But just to give you an orientation around pathologists and clinical informatics, a chief medical information officer is to an EHR what a director of pathology informatics or a physician informaticist is to an LIS, or what a director of radiology informatics is to a radiology information system. Pathologists who specialize in clinical informatics, such as myself, we provide medical oversight for the laboratory information system or systems, as many laboratories typically have more than one. We provide medical oversight for the laboratory components of an EHR. So in my case, I work closely with our Chief Medical Information Officer over anything related to the laboratory in our electronic health record. We also can be a very good resource for laboratory and information technology regulations, practice, and implementations, particularly because the laboratory has additional regulations in place that people not familiar with laboratory law may not be aware of. And there's of course similar correlates for radiologists who specialize in clinical informatics, as well as pharmacists with pharmacy systems. I did want to give a brief note about pathologists as clinical informaticists. Sometimes it seems surprising to people, but we actually have a very long history of clinical informatics practice. We have publications of laboratory information technology published as far back as the late 1940s. Laboratories were some of the first areas in hospitals to adopt computer systems because they helped us with our workflow, with calculations, and also helped our organizations ensure that they were billing appropriately for laboratory testing in our systems. We also note that the American Board of Pathology co-sponsored the application for the clinical informatics exam along with the American Board of Preventive Medicine, and as a result, if you're a pathologist, this means that you apply for the clinical informatics exam through the American Board of Pathology, and it's also that organization through which you do your maintenance of certification instead of the American Board of Preventive Medicine. I also, for kicks and giggles, sort of took a look at the number of people who had passed the clinical informatics exam as of up through December 2016 and compared that against physicians as a whole in the Federation of State Medical Board census. So I noted that 2% of all United States physicians are pathologists, but 6% of all board-certified clinical informaticists are pathologists. And all I think this notes is just the data-intensive nature of the field of pathology. This is why you'll see more of us, or a slightly higher proportion of us, becoming clinical informaticists than perhaps you might see in other specialties. So we're going to switch gears here a little bit and talk about laboratory regulations and electronic health records. And while many of you may know about CLIA, or the Clinical Laboratory Improvement Amendments of 1988, you'll realize that that law has far-sweeping implications for laboratories, and not just when it comes to information technology. However, most people may not realize that it actually does have a significant impact on how laboratory data has to be presented in an electronic health record. For those of you not familiar with CLIA, just to give you a little bit of background, basically CLIA was a massive overhaul of the Clinical Laboratories Improvement Act of 1967. And that overhaul was generated in response to really what was public fury over some very unnecessary deaths among patients. These deaths were due to false negative pap smear readings and to other laboratory errors that had taken place. And CLIA impacts every clinical laboratory in the United States. If you are a laboratory and you're performing clinical patient care, you must have a CLIA license, and you must abide by CLIA law. Fortunately, I'm not going to go through all of the requirements of CLIA. I'm going to stick to the ones that pertain to electronic health records. But you should be aware that 42 CFR 493.1291 is very important for electronic health records, and this is the test report standard, which mandates how and what data elements must be included in laboratory results reporting. You should be aware that CLIA regulates laboratories, not electronic health records, but they make the laboratories responsible for ensuring that their data is posting according to law. It is not always clear when you have laws like this where the laboratory's reporting responsibility ends with relation to the EHR, along with some of the regulations, because as many regulations are, they can be a bit ambiguous. But you should be aware that this standard is here. I've provided the reference for you, and we will talk a little bit about what is required as part of it. This is part of the test report standard. I think the main thing that you should take away from this is that the laboratory is responsible for ensuring that test results and other patient-specific data are accurately and reliably sent from the point of data entry, meaning the laboratory, to the final report destination in a timely manner. Now, the final report destination gets a little ambiguous, but if your physicians are primarily looking in their EHR for their laboratory data, then that would obviously be considered by many to be the final report destination. This slide provides you with a list of what must be included in a test report according to CLIA. I've bolded some of the things that tend to be points of contention when I'm discussing this with people regarding laboratory data being presented in an EHR. So, for example, the name and the address of the laboratory location, the physical address of where the test was performed, must be part of the laboratory test report. And if the EHR is the final report destination, then that name and address must be included somewhere. In addition to that, you must have units of measurement. You must have the test report date, the test performed, etc. You also need to have pertinent reference intervals or normal values. Those must be available to the authorized person who ordered the test. And so obviously these all have implications for what's included in your laboratory data in your EHR. Clinical laboratories have to be accredited by a CLIA-deemed agency every 2 years. These can include the College of American Pathologists, the American Association of Blood Banks, the American Society for Histocompatibility, COLA, and the Joint Commission. CLIA-deemed agencies are required to have all CLIA requirements at a minimum as part of their accreditation standards, but often they have more standards than what is required by CLIA, and some of those standards can actually impact electronic health records. So, for example, in the College of American Pathologists standards for the general laboratory, there's a phase 2 standard, and phase 2 is sort of the highest level of deficiency if you can't answer this standard appropriately, is that there's a procedure to verify that patient results are accurately transmitted from the point of data entry to patient reports, whether they are paper or electronic. And this has implications for laboratories, especially those reference laboratories that have 5,000 plus EHRs with which they interface. So they have to be able to address that requirement and ensure that their laboratory data is posting accurately. There was a study done in 2016 which studied 16 different lab tests at 45 institutions and looked at over 1,000 lab results. They were looking to see how many laboratories were actually compliant with this requirement to ensure that their laboratory results were accurately transmitted to the electronic health record according to CLIA test report standard requirements. What they found was that 99.3% of the laboratory data was accurately transmitted to the electronic health record, but I would note that's not 100%. All of the CLIA required result elements were only transmitted to the electronic health record in about 2/3 of cases, slightly over 2/3 of cases at 69.6%. If the institution had CPOE, or computerized provider order entry, for greater than 50% of their orders, then the median was far higher than if they did not have CPOE on board, which for most of you should be for obvious reasons. In addition to that, the most common CLIA elements that were missing from laboratory data in the EHR were the date and time of the test result or the report, as well as, like I said earlier, the name and address of the performing laboratory. And they also noted that most lab results were appropriately formatted in the EHR, although there were about 10% of lab results where the formatting might have caused problems with provider interpretation of the data. So I also want to let you know about another laboratory-specific regulation that definitely impacts entire healthcare systems and how they're able to release patient data or patient results to patients, and that's the patient access rule. So you'll see where this is located in the Federal Register to the right of the slide. You should be aware that prior to the patient access rule, under HIPAA, healthcare entities were required to be able to provide an individual with a copy of their designated record set health information, but they provided an exception for CLIA and laboratory results because CLIA pre-existed HIPAA, and it required that laboratories could only release laboratory results to an authorized provider or person who had ordered the test. So as a result of that exception, there were some practices whereby providers were requiring patients either to come in to see them and charge for another visit in order to get access to their laboratory data, and patients weren't able to get laboratory data directly from the laboratory themselves. So there was a bit of an outcry about this that was reported to the Office of the National Coordinator for Health Information Technology, who then coordinated between HIPAA and CLIA to write the patient access rule. Part of the stimulus, in addition to what I previously stated as to why the patient access rule was written, came from this paper where they examined laboratory test results in an electronic health record and then looked for documentation or evidence that the provider had communicated with the patient specifically about abnormal and clinically significant test results. And they found that in 7.1% of abnormal, clinically significant laboratory test results, there was no evidence in the EHR that the patient had been communicated with about them. So now, that certainly doesn't mean that that communication didn't happen, but it also means there was no documentation on it. So this is one of the reasons why the patient access rule was written. Now, if you download the patient access rule from one of the federal government websites, you will note that it is a document which is about 50 pages or more in length. What's interesting about that is that the patient access rule itself modifies HIPAA and modifies CLIA, and those modifications only represent about a column and a half of page text, which I have highlighted for you on the right-hand side of your slide in front of you. You should be aware that the patient access rule supersedes all state laws on the release of laboratory results to patients, because there are some states that previously had laws specifying that patients could not get access to their laboratory results except through their physician. It also applies to all CLIA certified laboratories and CLIA exempt laboratories who perform even just one HIPAA financial transaction. So as a result of the modifications made to both CLIA and HIPAA under the patient access rule, patients can now request a copy of their laboratory results that are contained within their designated record set directly from the laboratory. Now, the requirements for a laboratory to comply with this request are exactly the same as that for healthcare entities. Laboratories can refer a patient to medical records at their institution to comply with the rule, provided that medical records have all of the requested laboratory results for the patient and medical records is complying with the HIPAA regulations for release of information. There is absolutely no requirement for the laboratory to interpret the test results for the patient, and the patient does not have to get permission from their ordering physician or provider to receive the results. Reports must be compliant with CLIA reporting requirements if they are to be released. The last aspect of laboratory regulations that will be covered in this lecture include the fact that transfusion or blood banking information systems are regulated by the United States Food and Drug Administration. This is because these information systems are making recommendations and determinations on what blood products or organs or tissues are getting transfused or transplanted into patients, and therefore they're classified as a high risk or class 3 medical device. There is guidance from the Food and Drug Administration on how to validate these systems, and I have provided the reference to that below in this slide. The guidance on software validation has good recommendations for validation of software for health systems in general. Moving on from regulations, which are required, to standards, which are voluntary, it's possible you could be asked about the Clinical and Laboratory Standards Institute, or CLSI. CLSI is an international standards development organization which has a huge number of standards for laboratories in general, but as you can see to the right of this slide, there's also a number of these standards that apply to automation systems and laboratory information systems for laboratories. We're going to switch gears now to discuss communication between an electronic health record and one of its ancillary systems, and again, the primary example that we will use here is a laboratory information system. Starting with the challenges for laboratories, laboratory personnel may not actually have access to the electronic health record, and this means that they will have no way of knowing exactly how their laboratory data is displaying in the EHR. Needless to say, if the laboratory itself is not part of the healthcare system, these challenges can be even more significant. If you have a laboratory that has many interfaces with different EHRs, and this is the typical situation that you will see with reference laboratories, then they may have many EHRs that they have to make their laboratory data be able to interface with adequately. And every EHR has different ways that it displays laboratory data. You can also have an EHR which is receiving results from multiple laboratories, and that can also create some additional challenges. In addition, in some EHRs, there's software functionality which allows an end user who is not from the laboratory, and this could be a nurse or a provider or a pharmacist, who would be able to manipulate laboratory data after a laboratory result is posted to the EHR. This can occur without any knowledge from the laboratory, and needless to say, this would create a significant regulatory problem under CLIA. Many of these modifications are made with totally benign intentions. Someone's trying to make a note on a laboratory result to indicate that they reviewed it, but sometimes those modifications can actually impact the laboratory result such that the laboratory result appears to be corrected when it actually is not. In addition, laboratories may make manipulations to their laboratory results that may have an unseen impact to the EHR, which is lying downstream. When a laboratory makes changes to laboratory data and they aren't aware of the downstream impact, then obviously there's a potential safety risk if the changes cause the data to be misinterpreted by the provider or the end user looking at the laboratory results. Healthcare system employees who are not in the laboratory typically don't have access to laboratory information systems, so they also cannot compare views and are less likely to know in that situation when laboratory data is inaccurately displayed. Communication between an EHR and an ancillary system such as an LIS occur via system interfaces. Unlike user interfaces, which typically describe a graphical display that a user looks at when they're interacting with a computer application, a system interface is used to communicate information between two disparate databases. Greater than 90% of laboratory interfaces, and honestly, really greater than 99% of laboratory interfaces, are HL7 interfaces. HL7 is covered elsewhere in this course. HL7 interfaces must be real-time, meaning that the data is sent as soon as it is generated when you're dealing with clinical patient care activities. However, if you're dealing with billing or data warehousing, those HL7 interfaces can operate on a nightly basis and in a batched manner. There are very few custom and flat file interfaces in laboratory. Certain instrument interfaces require an upload and a download of certain file types in order to communicate between the instrument and the LIS. However, these are distinctly uncommon. This slide is really intended to represent the complexity of system interfaces that may be running in even a relatively small laboratory. This is often something that comes as a surprise to individuals who are not familiar with laboratory data and how data is managed between instruments, middleware servers, different laboratory information systems, and in some cases multiple EHRs. One thing to note is that many laboratories often communicate with external reference laboratories for those things that they don't perform in-house and need to send out to a reference lab. Clearly, this is beneficial because this prevents the laboratory from having to use manual data entry for orders and for results coming back in from the reference lab. Most laboratory instruments communicate with the LIS via HL7, and many fax servers, print servers, billing systems, and interface engines may also be communicating with one or more laboratory information systems within the laboratory. People frequently refer to system interfaces as bidirectional. However, there is a difference between a symmetrical bidirectional interface versus an asymmetrical bidirectional interface. Bidirectional interfaces simply have information flowing in both directions. They can be very complicated to set up. Symmetrical interfaces are those in which the same type of information is exchanged in both directions, and a primary example of this would be an HL7 ADT message or admissions, discharge, and transfer message, because the data elements in those messages are the same, passing back and forth between systems. An asymmetrical system interface, however, is where information flows in both directions, but the type of information is different. A primary example for a laboratory information system and an EHR is where you have orders flowing from the EHR to the LIS and results flowing from the LIS to the EHR. For those of you who have set up these asymmetrical interfaces, you'll know that not everything is 100% or set in stone. You can have an LIS, for example, send orders to an EHR, particularly reflex orders or additional orders that came in on paper. However, you generally don't see results flowing from an EHR to an LIS, although I would add that order prompts actually can come into some LISs in the form of pre-filled out results. So you can have some nuances here, but generally speaking, an asymmetrical interface is where the vast majority of the information and the flow of that information is different between the two systems. This diagram represents a prototypical HL7 orders interface between an EHR and an LIS. You'll notice that on the side of the electronic health record, orders are created, they are translated into HL7, and then those HL7 messages are sent across to the laboratory information system. The laboratory information system receives those HL7 messages. They translate those HL7 messages back into database records, specifically laboratory orders in the laboratory information system database, and then the laboratory information system can act on those orders. This slide shows a prototypical HL7 results interface, where results are generated by the laboratory information system. They are then translated back into HL7, and the HL7 headers and information that is passed is distinctly different from what you would typically see with orders. Those HL7 messages are then transmitted back to the EHR. The EHR receives those HL7 messages. They translate those HL7 messages back into their own database records of results, and then end users are able to use the laboratory results to help take care of patients. In contrast to bidirectional interfaces, unidirectional interfaces are system interfaces in which the information flows in one direction only. Common examples of unidirectional interfaces include information flowing to billing systems, data warehouses, print servers, fax servers, mobile device messaging systems, etc. Unidirectional interfaces can be less work to implement, except that in unidirectional interfaces, especially when you're talking about print servers, fax servers, think about all the little label printers that you may have everywhere. You may have to test against many different devices in many different locations, so they actually can be a lot of work to implement. But they're still extremely important, obviously, because they can drive workflow. Many places wait to see a printed document or a fax document or a printed label before they actually start their next action in their workflow process. So it's very important to make sure that these unidirectional interfaces are working. Obviously, billing queues are incredibly important to our healthcare institutions, and as you can imagine, when one or more of these unidirectional interfaces are not working, you not only have a lack of workflow triggers, but you may not be able to bill. Last but not least, it's important to point out for any of you who have been involved in a downtime of a unidirectional interface, the lack of a visual trigger can often result in delayed detection of a problem. It isn't until several hours later that people think, I haven't gotten a printed label or a printed document or a fax document in a while. I wonder if there's a problem. While it's common to have interface alarms on bidirectional interfaces, I haven't seen them as commonly used with unidirectional interfaces, but the delayed detection problem may warrant implementation of an interface alarm depending on the critical nature of those workflow triggers. Many larger laboratories and also pharmacies use what are called automation lines or robotic lines. These are robotically operated tracks which move specimens or medications, in the case of pharmacy, from the point of entry to the next device that will be manipulating that item. In the case of a laboratory, that would be an instrument that would be performing a test on the specimen in the track. For laboratory automation lines, the automation line has a barcode reader on it. That barcode reader will scan the specimen label barcode. It will look at the accession number or other identifier within the barcode, and it will query the laboratory information system for any pending test orders on that specimen. Once it receives those orders and then associates those orders with the instrument that will be performing the test, it sends the sample down the robotic track to the appropriate instrument for testing. Auto verification is a term that seems to be limited, to my knowledge, to laboratories, and it is a process whereby the laboratory is using computer-based algorithms to automatically determine if a laboratory test result can be automatically verified and released back to an electronic health record. The computer algorithms that are put in place are actually intended to identify those samples that cannot be automatically released and which need to be looked at by a medical technologist, a laboratorian, or a pathologist before they can be verified and sent into the electronic health record. Auto verification systems are typically managed through the use of middleware. And in a laboratory, middleware is typically software that sits on a separate server between a laboratory instrument and the laboratory information system, and typically they perform functions on laboratory data that aren't available in the laboratory information system itself. An example of auto verification is when you have results that fall within certain reference ranges considered to be normal or slightly abnormal that can be automatically verified by the system. And this relieves the need for a technologist to manually verify those results and can dramatically reduce turnaround time. Laboratories that use auto verification can frequently do almost 10 times as many laboratory tests with the same number of employees as they can when auto verification is not in place. However, when auto verification is not working in a laboratory that already has had it installed, the volume may quickly outpace your laboratory staff's ability to keep up with test volume. Barcodes are used in healthcare to a great degree, and their usage is ever increasing, especially with the advent of positive patient ID systems for barcoded medication administration, as well as for specimen collections and transfusion verification. Barcodes are basically machine-readable codes or graphics, which are used to represent alphanumeric characters, and in the laboratory these barcodes are used to represent typically accession numbers, encounter numbers, or container IDs. Obviously, in other areas of healthcare, patient armbands have barcodes, medications have barcodes, and we will describe those in just a moment. The obvious advantages of barcodes are that they reduce manual typing errors because they eliminate manual data entry, and they also greatly improve the speed of data entry by orders of magnitude. Regardless of where you are using barcodes, I would give you my very strong recommendations, which are supported by multiple guidelines. When you have a barcode either on a patient armband or on a label, the human readable version of the encoded data in the barcode should always be printed next to the barcode. This eliminates the possibility that you run into a situation where a barcode reader is not available and you're not able to identify the number or identifier that the barcode is intended to represent. There are two major types of barcodes used in healthcare today. One is one-dimensional or linear barcodes, some examples of which I have shown on this slide, and the other category is two-dimensional or 2D barcodes. The advantages of linear barcodes have already been described. However, linear barcodes have a number of disadvantages associated with them, despite their common use in healthcare. Linear barcodes are actually quite space intensive. They take up a lot of real estate on a label or a patient armband for the amount of data that are encoded in them. In addition, linear barcodes are quite prone to problems if they are damaged or misprinted in any way. These problems can result in non-read errors where the barcode cannot be read by the barcode reader, but worse, they can result in substitution errors where the data is decoded incorrectly. And this is another reason why it is very important to print the human readable version of what is intended to be in the barcode next to the barcode on any armband or label containing one. In a study that was done by myself and a few others, we discovered that the actual error rate of linear barcodes was approximately 1 in 88,000, and these were substitution errors, not non-read errors. Another disadvantage of linear barcodes is that typically a linear barcode will only contain the piece of data, but will not contain any reference as to what type of data was encoded into the barcode. So for example, when you scan a barcode and it results in a series of numbers, you have no idea of knowing if that represents a medical record number, a financial number, a master patient index number, or an accession number on a patient. In contrast to linear barcodes, two-dimensional barcodes or 2D barcodes have data represented in two dimensions. There are two major subtypes of 2D barcodes: the stacked one-dimensional barcode, an example of which is PDF 417 shown to the right, and matrix barcodes. The prototypical examples of matrix barcodes include the QR code, data matrix, and Aztec. To the right of your screen, you will see PDF 417, data matrix, and QR code representations of the AMIA Clinical Informatics Board Review course. As you'll note, the data density for these barcodes is quite high, so you're able to get that amount of information into a small area. If we represent the AMIA Clinical Informatics Board Review course in a linear barcode, specifically code 128, you'll see that that barcode takes up much more space and certainly would not be usable on most of the formats that we use in healthcare. While linear barcodes are certainly far less error-prone than manual data entry, as you can see from the error rate statistics in this slide, linear barcodes still have several orders of magnitude more errors than you would see in a two-dimensional or matrix barcode. In addition, if you read the theoretical substitution error rates for linear or one-dimensional barcodes, you'll note that the mathematical estimation is 1 error for every 2.7 to 37 million scans. Because the error rate is mathematical, it doesn't take into account damage that can occur to a barcode after it has been printed or even before it has been printed by printer pin misfires. As a result, the actual error rate for linear barcodes is far higher than expected, and I think most of us would agree that an error rate of 1 substitution error in 88,000 scans is far too high for healthcare nowadays, especially with the number of patients and tests and specimens and armband barcode scans that are currently being performed. The error rate seen with two-dimensional or matrix barcodes is multiple orders of magnitude lower than that seen with linear barcodes, and even though this error rate is mathematical, there are other aspects of two-dimensional barcodes which help protect against substitution errors. To help you differentiate between linear and two-dimensional barcodes, I have included a chart on this slide which compares the differences between these two types of barcodes. Unlike linear barcodes, two-dimensional barcodes can encode data multiple times, and this allows them to develop damage and printer error correction and detection algorithms that even if the barcode is damaged, there may be other areas of the barcode which are intact and can be read by the decoding algorithm. The vast majority of linear barcodes that exist, and this includes those UPC barcodes that you may use in the grocery store, have no data integrity checks, meaning there's nothing in the algorithm to help alert you that the barcode may have been misread. Code 128 is the standard linear barcode that is used in healthcare, and even this barcode only has a single data integrity check, which isn't very robust. By contrast, two-dimensional barcodes typically contain multiple data integrity checks, and these may occur in multiple axes of the barcode. So you may be asking yourself, why doesn't everyone use two-dimensional barcodes? And the answer is fairly easy. They aren't the easiest barcodes to install, particularly if you want to use multiple data elements within them. This is why most areas have implemented linear barcodes, because they're easy to install and they basically don't require any additional software in order to read or parse the data. Over the next two slides, I am showing you the current standards in place for various barcodes used in healthcare. The first is the CLSI Auto 02A2 standard. This is the standard that is currently in use by laboratories for clinical laboratory specimens. You'll note that the required barcode symbology is code 128 because it has a required check digit. Code 39, which has an optional check digit, was deprecated years ago and really should no longer be used in any location. There's another standard, which is the CLSI Auto 12A standard. This regards the human readable component of laboratory specimen labels only and not the barcode itself. There is another standard that CLSI has in development that will help laboratories transition to two-dimensional barcodes. This is known as the Auto 14 and as of this date has not yet been published. The next barcode standard is the ISBT 128 standard. This standard is for barcode labeling of medical products of human origin, otherwise commonly known as blood products. These require the use of either code 128 or two-dimensional barcodes. Now, given what all I've said about linear barcodes, you may be concerned that linear barcodes for use on blood product labels would be problematic. However, the ISBT 128 standard goes far beyond and away the typical implementation of most linear barcodes. This standard has certain stringencies not only for the data elements that are included, but also for the software that actually reads, parses, and interprets the encoded data once it has been read out of the barcode. While linear barcodes are certainly the most common among blood product labels, two-dimensional barcodes that meet certain criteria are also acceptable. The ISBT 128 system replaced CODABAR as the safety labeling standard, and it is the only barcode labeling standard which is accepted by the Food and Drug Administration for blood products. There is no barcode standard for anatomic pathology specimens, which includes surgical pathology specimens and some cytopathology specimens. However, the College of American Pathologists recently released a uniform labeling of blocks and slides standard, which does apply to the human readable components of labels on anatomic pathology specimens. The previously mentioned standard that CLSI is developing for two-dimensional barcodes will apply to both clinical laboratory and anatomic pathology specimens, so there is a standard that is in progress for these types of specimens. As many of you know, barcoded medication administration is being implemented in many of our health systems, and there is a barcode labeling standard for medications. This barcode labeling standard has been put forth by the Food and Drug Administration, and we will cover this in more detail on the next slide. There is currently no standard for the barcodes placed on patient armbands. As you know, these patient armbands are being used for positive patient identification for barcoded medication administration, specimen collection, and transfusion verification. So the barcodes that are being used on patient armbands are very critical, but lack a defined standard as to what should be included in the barcode, how robust those data elements are, nor whether there should be additional software checks for the data to ensure that they are being read correctly and not misinterpreted as a different patient. In the United States, drug labeling is regulated and mandated by the Food and Drug Administration, and this includes the barcode label requirements. FDA regulations stipulate that only certain entities must place barcodes on drugs, and interestingly enough, hospitals are exempted from this requirement. Drug barcodes must contain, at a minimum, the appropriate national drug code number in a linear barcode format that meets either the EAN.UCC standards or the HIBCC standards. The references for those standards are at the bottom of the slide. In addition, the barcode must be surrounded by sufficient blank space, also known as a quiet zone, so that the barcode can be scanned correctly, and they also must remain intact under normal conditions of use. Another machine-readable identification, which is frequently confused in function with barcode labeling, is radio frequency identification. In radio frequency identification, or RFID, radio waves broadcast data from an electronic tag that's mounted on an object to a scanner or a reader. In some cases, the tag can be read from several meters away and often beyond the line of sight of the reader. This enables the potential for bulk reading of multiple samples at one time. And nowadays, if you've looked at your U.S. passport, you'll notice that the cover is much thicker and stiffer than it was before. This has to do with the fact that there is an RFID chip now in your U.S. passport. Many of us also have RFID chips in our badges. Radio frequency identification tags come in three main flavors, which consist of two types and a hybrid type. The first type is a passive RFID. A passive RFID tag does not have an onboard battery, and it can only emit signal when it has been pinged directly by a scanner. An active RFID does have an onboard battery, which is constantly emitting the RFID tag signal, kind of like a beacon. Active RFID tags are typically used on larger pieces of hospital equipment that you want to know where their location is at any point in time. A battery-assisted passive, or BAP RFID, is an RFID tag that has a small battery on board, which, when it's activated by the scanner, can emit its signal for up to 10 seconds after it has been pinged by the reader. So again, here is a chart to help you contrast and compare barcodes and RFID tags. Barcodes must be in the scanner's line of sight, but an RFID tag does not always have to be. You cannot do bulk scanning with barcodes, but you can do bulk scanning if you have items which are tagged with an RFID tag. Barcodes are more prone to damage than RFID tags, and RFID tags can be used to locate a missing specimen if that specimen has been labeled with an RFID tag. A barcode obviously has no such capability. There are, however, a couple of disadvantages to RFID tags. The first is that if an RFID label is printed but then discarded and not applied to a sample or other piece of equipment, if an RFID scanner picks up the signal of that discarded tag, it may have already recorded that tag as being meaningful in a particular workflow, and that may cause confusion to the end users later on. In addition, because an RFID tag is emitting a signal electronically, it is harder to make it compliant with the final security rule of HIPAA, which is covered elsewhere in this course. RFID tags are also much more expensive than printed barcodes on a label, and RFID tags, if they are placed too close to each other, they can cause interference with the signals that are emitted. Laboratories, for example, that have tried to put RFID tags onto glass slides have found that this has not been an effective way of tracking those glass slides, because when the slides are stacked next to each other in a drawer, they interfere with each other's signals. Okay, so as a break during the session, let's consider the following question. According to the patient access rule, which of the following is correct? A, patients must go to medical records to obtain a copy of their laboratory data. B, patients are entitled to their laboratory results immediately after requesting them. C, patients can request only verified results directly from the laboratory. And D, patients have to get permission from their physician to request a copy of their lab results. The correct answer is C, patients can request only verified results directly from the laboratory. The reason why A is not correct is because patients do not have to go to medical records. They can go to the laboratory directly and obtain a copy of their laboratory results. The reason why B is not correct is because patients are entitled to their laboratory data, but they are not entitled to them immediately. This is the same rule as with medical records. Medical records and laboratories have up to 30 days to release the data to a patient after the request is made. The reason why D is not correct is the entire reason why the patient access rule was created, is that patients do not have to get permission from their physician in order to request a copy of their laboratory results. Let's consider another question. Two-dimensional barcodes are superior to linear or one-dimensional barcodes because A, barcode readers know what data is encoded in a 2D barcode automatically, but they don't with 1D barcodes. Answer B, 2D barcodes never require special software in the laboratory information system to read them, unlike 1D barcodes. Letter C, 2D barcodes contain multiple data elements, where 1D barcodes can usually only contain just one data element. And D, 2D barcodes are easier to set up and install than 1D barcodes. So the correct answer is C. 2D barcodes, as we described, can contain multiple data elements, where 1D barcodes usually can only just contain one data element. The reason why answer A is incorrect is that barcode readers don't know what data is encoded in either a 2D or a 1D barcode at all. It requires special additional software in order to read and parse the data if you have included identifiers to describe what is in the 2D barcode. With 1D barcodes, this capability of identifying the piece of data is extremely limited, although this does occur in ISBT 128 barcodes. The reason why answer B is incorrect is because 2D barcodes frequently require special software in the laboratory to read them, particularly if you have multiple data elements encoded within a single barcode. 1D barcodes, on the other hand, almost never contain multiple data elements unless you're talking about ISBT 128 barcodes, and therefore 1D barcodes are far less likely to require special software in order to decode them. The reason why answer D is incorrect is because 1D barcodes are actually easier to set up and install than 2D barcodes, as we previously described. Switching gears now to digital imaging. A pixel is the smallest component of an image, and that can be the smallest component of either a printed or a digital image. Image size simply refers to the overall width by height of an image in its final form, whether it's digital or printed. It contains no information on the image resolution. While the image size may not seem important because images can be enlarged or reduced as needed, it is important to know the overall size of the final image that you are desiring to use, because this will have an impact on what resolution you decide to use to capture the image. Image resolution is also known as pixel density, and you'll commonly hear it referred to as dots per inch. This can refer to dots per inch on a computer or digital medium or on printed media. The average image resolution of a computer screen is typically between 96 to 120 for Windows machines and maybe a little bit lower for Macs. However, the average minimum printed dots per inch can be 300, and that can be increased significantly depending on the quality of the printing that is being performed. Computer monitors will frequently give you options on the image resolution on the computer monitor, and generally speaking, higher is better, but you need to determine the dimensions of the overall screen when making those determinations, because referencing pixels in width by height does not really indicate resolution because there's no information on the actual screen size. When taking a digital image, it is important to understand what the final purpose of the image will be. If you are taking images which don't require a high degree of detail, then low resolution is certainly acceptable. In pathology laboratories, if we're taking gross images of organs, for example, low resolution works perfectly fine for those. Photomicroscopic images, on the flip side, which often require some level of resolution to detect fine changes in nuclear detail, those images require high resolution. Similarly, if you are taking a small-sized image, low resolution would be acceptable for those, whereas if you're taking an image that's going to be projected on a very large screen, high resolution would be preferable in order to avoid pixelation, which is a term that refers to the ability of the human eye to see the actual individual pixels in an image. In an image which is taken without compression, each individual pixel has a byte for red, a byte for green, and a byte for blue characteristics at that pixel. When you multiply an individual image over its millions of pixels at 3 bytes per pixel, you can come up with a very large amount of memory assigned to an individual image. As a result, software engineers developed image compression, which is a process whereby mathematical algorithms are used to reduce the amount of memory that an image occupies. Image compression may be lossy or lossless. In lossless image compression, the memory or the file size is reduced, but all the original image data can be recovered once the image is re-expanded into view. Examples of lossless images include PNG and GIF file types. Lossy image compression, by comparison, is when after the image is compressed, some of the original data in the image is gone forever, and the amount of compression is proportional to the amount of loss. However, nowadays there are several lossy image compression algorithms which are quite well designed, and you can have substantial data reduction without obvious loss to the human eye. Standard JPEG files can fall into this category depending on the level of compression that's used. You should note that lossy and lossless compression can also be referred to for audio files, such as the audio file that I'm using to record this presentation, as well as video. Fortunately, on the board exam, you're not going to be asked about the details of how compression algorithms are enacted. However, I did want to give you a basic, really oversimplified model for how image compression works. So, for example, as you can see in this histologic slide image, there are areas within the image that have approximately the same color. These would be areas in the image which are the clear glass pieces. Each one of the square boxes that I've outlined in the image are actually hundreds if not thousands of pixels depending on the image resolution that's used. Image compression algorithms look for pixels that are effectively the same color and instead map them to an area rather than referring to each pixel individually by its 3 bytes of color. In lossless image compression, an algorithm might map only those pixels which are exactly the same color together, whereas in a lossy image compression algorithm, they may pick pixels which are close to but not exactly the same in color, and this is how you can lose the original color data in the photo. Now, we can't talk about images without also talking about picture archiving and communication systems, or PACS. PACS are computers and servers which are dedicated to storage, retrieval, distribution, and presentation of digital images, but they often have a huge number of functionality components such as image annotation, workflow, interpretation, and reporting. In the last 20 years, there has been a huge upswing in the use of PACS in radiology departments, the increase you can see on the slide. Sadly, despite the high use of images in pathology departments are much less likely to have a PACS. A newer term in image management that you could be asked about on the board exam is that of the Vendor Neutral Archive, or VNA. Theoretically, a VNA is a single image repository or database that is able to house or federate all desired images regardless of their source, their data type, or the vendor or manufacturer system that created them. The purpose of a VNA really is to create a one-stop shop for all image archiving and dissemination, and that would include for radiology, cardiology, endoscopy, pathology, etc. A VNA should provide viewer support either directly or via a third party, and while it is called a vendor-neutral archive, unfortunately no VNA works with absolutely all image types, but some can get close. The term telepathology has a specific definition and does not refer to just any use of digital images in pathology. Telepathology specifically is when a digital image is being used by a pathologist to render a diagnosis that results in a clinical report on a patient. Moreover, examination of the glass slides cannot be part of the diagnosis. While telepathology and teleradiology may seem to be very similar, there's a big difference between telepathology and teleradiology, and that is, unlike teleradiology, images cannot be acquired directly from the specimen or patient. The specimen actually has to go through grossing and tissue processing, sectioning, staining, cover slipping, and then once a slide is created, the image can be scanned. The vast majority of telepathology practice requires the use of a whole slide imaging system. These systems are specialized image acquisition devices. They have extremely high resolution capability. As a result, a single uncompressed image of an entire slide at 40x resolution will render an image that's about 50 gigabytes in size. The use of whole slide imaging devices can occur clinically through a specified validation pathway under CLIA, but it also can occur if you use an FDA-approved whole slide imaging device. Now, the FDA recently downgraded whole slide imaging devices from Class 3 to Class 2, which would enable them to go through the 510K pathway. Final guidances for whole slide imaging devices are provided as references on this slide. Because of the image sizes and the amount of time it takes to acquire each whole slide image, there are various types of telepathology which you could be asked about on the exam. Static telepathology is when the entire image is captured and then transmitted, and the transmission can either be in total or in pieces. Static transmission is obviously the most common form of transmission in teleradiology, but in telepathology there are certain workflows that don't support the amount of time that it takes to capture an entire image and then transfer it. So dynamic telepathology systems were developed which are effectively live video feeds with or without remote control of the scanner or microscope under which the slide is being examined. Hybrid telepathology systems do both. They have a dynamic component as well as a static component, and typically in frozen sections what happens is that a thumbnail view of the entire slide is captured, and then remote video feed can be used to drill down, so to speak, on various areas of the image in order to render a diagnosis within the time required for a frozen section. When it comes to images, it's also important to talk about the Digital Imaging and Communications in Medicine standard. This standard was originally developed in radiology and also expanded quite quickly into cardiology, but now it also involves pathology and other specialties. This is the international standard for medical images and related information. Within DICOM, Working Group 26 relates to pathology, and supplements 122 and 145 are for whole slide imaging specifically. These are just a few notes on telepathology regulations, especially for those of you who are more used to teleradiology or telecardiology. Telepathology regulations vary greatly from state to state. They are not the same as teleradiology, and CLIA still applies to laboratories when telepathology is being performed, and that can create some special challenges. The College of American Pathologists has also included telepathology standards in their laboratory accreditation documents. So now we're going to switch gears and talk about bioinformatics and next generation sequencing. Now, this is obviously a clinical informatics board review course, and so some of you might be wondering why we're including a little bit about bioinformatics in it. However, when it comes to next generation sequencing and genomic testing, this Venn diagram illustrates the intersection of clinical informatics, bioinformatics, and genomics. Next-generation sequencing is becoming more prevalent in all areas of medicine. A more appropriate but less commonly used term for next-generation sequencing is massively parallel sequencing. And that is because DNA is sequenced in short overlapping fragments and then aligned to a reference, and then the variants from the reference are detected. In this slide, you can see an example of what many pathologists and laboratorians look at when they're interpreting massively parallel sequencing or next-generation sequencing. This piece of software is the Integrated Genomics Viewer from the Broad Institute. Each one of the gray bars that you see represents sequence, and the direction of sequence is shown by the tip of the arrow on the end of the sequence. Places where that sequence differs from the human reference genome are indicated by a letter indicating the base that the patient has compared to the human reference, which is shown in the string of nucleotides that you see down at the bottom. The most important thing for you to realize about this diagram is that this data is generated through one or more bioinformatics pipelines. Unlike the old days of molecular pathology, there are no gels or electropherograms to look at, so the pathologist or laboratorian is 100% dependent on the accuracy of these bioinformatics pipelines. Because next-generation sequencing is becoming ever more prevalent in clinical patient care, and because this is a clinical informatics board review course, it is important to understand the clinical informatics of genomic information. Next-generation sequencing is extremely high-throughput genetic analysis, and it differs from almost every other kind of laboratory testing in that it is absolutely dependent on intensive computational processing. The interpretation of next-generation sequencing data is a good example of big data analysis, and genomic information is coming under increasing United States federal government scrutiny. Moore's Law is covered elsewhere in this course, but effectively Moore's Law refers to an observation made by Intel co-founder Gordon Moore in 1965, where he noticed that the number of transistors per square inch on integrated circuits had doubled every year since their invention. A lot of people have transitioned Moore's Law into computer processors that double their capacity every 2 years at half the cost. In this graph from the National Human Genome Research Institute, you can see the comparison of Moore's Law against the cost per genome sequenced. Back in 2001, the Human Genome Project was underway, with the final results coming through in 2003. At that time, it was estimated that it cost about $100 million to sequence a single genome. Massively parallel sequencers started becoming more available towards the end of 2007, hence the drop in cost seen at that time. Additional advances in the technology occurred in early 2015, and the cost has dropped even further, such that a whole genome now only costs approximately $1,000 to obtain. This slide is just another representation of the advances that next-generation sequencing have brought to us. When I was a molecular genetic pathology fellow, we could only test one gene at a time at very high cost, and we certainly never dreamed that we would be testing an entire genome. Nowadays, we can sequence many genes at one time. The cost has dramatically decreased, and the end result is that we can examine much more of the human genome with less money. In addition, genomic discovery has increased exponentially. Now, because this is a clinical informatics board review course, I would be remiss if I did not describe a little bit about bioinformatics pipelines, specifically related to things that you might potentially be asked about on the exam. It's important to realize that a bioinformatics pipeline basically means you have multiple sets of one or more computational algorithms performed in series to analyze biologic data. Bioinformatics pipelines are absolutely not limited to next-generation sequencing data. They can be used for other types of biological data. Because there are multiple sets of algorithms involved in even just a single bioinformatics pipeline, it's critical to collect and check quality metrics along the way. To the right of the slide, you'll see a basic structure for a bioinformatics pipeline that would be used in next-generation sequencing analysis. So beginning at the top, a next-generation sequencing instrument will produce raw sequence data, and one of the first steps in a bioinformatics pipeline is to take the raw sequence data and translate it into FASTQ or unaligned BAM files, depending on the technology that you are using. FASTQ and unaligned BAM files are files which list all of the generated DNA sequences that you got from the patient sample. The bioinformatics pipeline will then align those sequences to the human reference genome and generate a sequence alignment map or SAM file, and then compress that file into a binary version, which is called a BAM file. The BAM file, and other versions are called CRAM or CCRAM files, are files which say where each sequence that was generated aligns to the human reference genome. The next step in a bioinformatics pipeline then is to take those alignments and look for where the patient sequence differs from the human reference genome. That generates a variant call format or VCF file, which is a list of the variants of the patient sequence from the human reference genome. There's a final step in the bioinformatics pipeline which looks for known false positive variants, data quality issues, and other DNA quality indicators before rendering the final list available to the interpreter. Discussions of next-generation sequencing are frequently accompanied by discussions of big data. The term big data is often used inappropriately, so it is important for you to understand the definition of big data. Here recently, Dr. Hirsch and I have both discovered that there are multiple definitions of big data out there, with some groups reporting as few as 3 Vs and as many as 7 Vs, depending on who you read. Dr. Hirsch and I have decided to center our definition around that issued by the National Institute of Standards and Technology. NIST has a series of publications on big data, and I've referenced the definitions document below. When most people talk about big data, they are simply thinking of volume. However, volume is only one aspect of big data. In the NIST definition of big data, there are 4 Vs: volume, variety, velocity, and variability. Volume obviously means large amounts of data, where variety means many different types of data. This means that your big data resource may contain audio files, text blobs, discrete numeric data, and images. Velocity means that the big data resource is constantly accumulating new data, and variability means that the data itself can change over time. People often associate big data with next-generation sequencing, in part because the file sizes, particularly for whole genome or whole exome sequencing, are very large, on the order of terabytes. However, while next-generation sequencing files have volume, they usually lack velocity, variety, and variability unless you are in an extremely high-throughput laboratory. Having said that, people who interpret next-generation sequencing data into a clinical report routinely use big data resources to assist with the interpretation because genomic discovery and implications of certain variants are changing on an almost daily basis. These big data resources are online and constantly being updated by multiple and often anonymous resources, and the data can be unstructured and is often uncurated, which means that the interpreter must use caution when using these databases to interpret data. I listed examples of these big data resources at the bottom of the slide. Some might be surprised to find PubMed in this list, but remember that PubMed contains papers from many different journals, and as has been discussed elsewhere in this course, there is a large amount of published data which are unreliable because the methods were poor and or incorrect conclusions were reached. Another area in laboratory medicine that is frequently associated, often erroneously, with big data is whole slide imaging. Again, whole slide image files have large volume per file. As we discussed earlier, this can be on the gigabyte range. However, they generally lack velocity, variety, and variability unless you're in an extremely large whole slide imaging laboratory that has constant and continuous acquisition of whole slide images from multiple patients and locations on different whole slide imaging instruments that produce image files of different types. What's interesting about big data is because the definition is not well known, many people may not realize that they're interacting with big data resources on a daily basis in healthcare. Clinical information systems such as laboratory information systems, radiology information systems, pharmacy systems, electronic health records, these are all examples of big data resources. And the reason is because these information systems have large amounts of data, they have many different types of data, they're constantly accumulating new data, and the data can change over time. Anyone who's ever had to correct a note, correct a laboratory result, will realize that the original data that may have posted to the record has changed since its original inception. To further illustrate the differences between small data and big data, I've created this visual for you. Small data is often structured at its outset. As you can see here, there is a nice orderly distribution of vegetables in the grocery store, which you could then take home, use a set of tools and a recipe, and then generate into something actionable. This is analogous to taking structured health data, using some computational tools or calculations on it according to a prescribed mechanism, and then generating actionable data as a result. With big data, you start with the equivalent of an unstructured, weedy vegetable garden patch, and that requires a set of additional tools as well as additional knowledge in order to convert that unstructured data into structured data before it can be further analyzed. Obviously, once you've gotten your data into a structured format, you can then use your usual tools in order to get actionable data at the end. Computational pathology is a new field in pathology where pathologists and scientists use already existing multi-parameter data along with computational analysis of that data to generate new clinically significant information about a patient. A published example of computational pathology is where computational analysis of simple CBC data is used to predict which patients are at risk for anemia before they show clinical evidence of it. Since we've been discussing the clinical informatics of genetic and genomic information, I thought it was appropriate to discuss a few of the federal regulations which have direct import into genomic data privacy. The HIPAA Final Security Rule and HITECH have both been covered elsewhere in this course, so I will be focusing on the impact of the Genetic Information Non-Discrimination Act as well as the HIPAA Omnibus Rule to genomic data privacy. The Genetic Information Non-Discrimination Act of 2008, otherwise known as GINA, is most often associated with its prohibitions that prevent insurance and group health plans from accessing, collecting, or requesting genetic information on patients. However, what many people don't realize is that it also required the Department of Health and Human Services to rewrite sections of HIPAA that would specify that genetic information was protected health information. As you can see from this slide, genetic information is defined under GINA very broadly. If you take a conservative approach to this definition, then practically any genetic information on the patient has to be treated the same way as a patient name or medical record number. GINA did exclude non-genetic laboratory results by specifically stating that genetic information did not include an analysis of proteins or metabolites which were directly related to a manifested disease, disorder, or pathological condition. So in 2013, the requirement for the Department of Health and Human Services to classify genetic information as protected health information under HIPAA was effected in the HIPAA Omnibus Rule. Now, there is a significant gray area in classifying genetic information as protected health information because there are lots of genetic variants which are shared across multiple individuals such that identifying such a variant could not possibly help you identify a single individual. However, with the advent of next-generation sequencing and the presence of benign polymorphisms, the combination of which could identify an individual patient, caution is advised in disclosing any genetic sequencing information on a patient. Obviously, this has huge implications for research on genetic material, and it is the first example of laboratory-generated data that cannot be de-identified without altering the data you are seeking to examine. Shortly after the HIPAA Omnibus Rule was effective, the NIH issued a genomic data sharing policy, which specified that for NIH-funded studies, investigators must obtain informed consent from prospective subjects, even if the cell lines or clinical specimens were otherwise de-identified. The policy also requires investigators to inform participants about the risks of re-identification and specifically states that it is no longer ethically tenable to simply de-identify clinical specimens or derived cell lines to generate data for research use without an individual's consent. Some of you may be familiar with the book The Immortal Life of Henrietta Lacks. Henrietta Lacks was the source of the HeLa cell line, and her re-identification is one of the main reasons why cell lines are included in this policy. That's a wrap for this lecture. I hope you found it informative and helpful in your studies for the board exam.